Hi, everybody. I am Dr. Adam Kittai. Welcome to the first presentation of ACCC's three-part knowledge series on CLL treatment strategies, sequencing, and care optimization. Today, I'll be talking about the first part of the series, where we'll go over CLL treatment strategies. I am an associate professor and CLL clinical research leader at the Icahn School of Medicine at Mount Sinai Hospital in New York, New York. I serve on the advisory committee for this program along with Dr. Jennifer Woyach, professor of medicine, leukemia, and hematologic malignancies, program co-leader at Ohio State University in Columbus, Ohio. As you may all know, there has been changes to the NCCN guidelines over the last few years. Currently, for preferred regimens for the treatment of CLL, these include acalabrutinib plus minus obinutuzumab as continuous therapy, zanubrutinib as continuous therapy, and venetoclax plus obinutuzumab as a time-limited therapy for 1 year. I think what's the most interesting thing about the change in the NCCN guidelines is that ibrutinib is no longer considered a preferred regimen and is now listed underneath other recommended regimens. This is based off of two phase 3 clinical trials that compared ibrutinib to acalabrutinib and ibrutinib to zanubrutinib and showed that the second generation BTK inhibitors acalabrutinib and zanubrutinib were both safer than ibrutinib. In one of these trials, the ibrutinib versus zanubrutinib study, zanubrutinib actually led to an improved PFS benefit as well. Additionally, chemoimmunotherapy has really come down from preferred to recommended and now is only useful in certain circumstances. I very, very rarely use chemoimmunotherapy. Sometimes you can justify its use in the inpatient setting if you have trouble getting approval for BTK inhibitors or venetoclax, but overall, in general, I have not used chemoimmunotherapy very much for the last 5 years. In terms of second line or subsequent therapies, it's the same therapies that we just went over. Typically, I use these therapies if I haven't used one of these therapies in the front line, and we'll talk a little bit about this in subsequent slides. Interestingly, pirtobrutinib, a non-covalent BTK inhibitor, was just approved after both patients treated with venetoclax and BTK inhibitor regimens, and we'll go over the data today. Lastly, CAR T-cell therapy is also approved and underneath useful in certain circumstances in the NCCN guidelines, and we'll go over the trial, the Transcend 004 study, today as well. To start off, as we all know, when patients are diagnosed with CLL, we don't typically start treatment. We usually start them on what we call watch and wait. I like to call it active surveillance. And the reason why I like to call it active surveillance is because we do things during this time. And I think that the patients find this beneficial because they feel like they're actually doing something about their CLL, when oftentimes they struggle and ask me questions, well, what can I do about it, doc? So we'll go about talking through some of the things that patients can do while they're on active surveillance. As a reminder, we wait for IWCLL criteria for treatment, and that includes cytopenias such as hemoglobin less than 10, platelets less than 100, big lymph nodes greater than 10 centimeters, a spleen that's 6 centimeters below the left costal margin, and a lymphocyte doubling time less than 6 months. We also consider treatment for CLL in other rare circumstances, such as relapsed refractory autoimmune cytopenias. And I want to remind everybody that these indications to treat are somewhat subjective in that some patients have long-term thrombocytopenia, and I may not start treatment if they platelets drop just less than 100 on one time. I often observe my patients and watch trends in these symptoms and these signs, and not all patients are created equal. So overall, these are the IWCLL criteria for treatment, and usually I wait for one of these treatment indications to be met before starting therapy. Oftentimes, my patients will ask me, why active surveillance? This paradigm was first created back in the 1990s, where patients were treated with chemoimmunotherapy, randomized to either chemoimmunotherapy or placebo, who did not meet indications to treat. And it found that patients treated with chemoimmunotherapy actually had a lower overall survival than those patients treated with placebo. Now, this paradigm is being re-challenged in the era of our new therapies, and this is the result of one study that compared ibrutinib to placebo in high-risk patients who did not meet indications to treat. And as you see here, patients treated with ibrutinib compared to placebo had exact same overall survival, but actually had higher toxicity. I think my big take home here is that patients treated with placebo who do not meet indications to treat have high rates of grade 3 adverse events. meaning that patients who are in this active surveillance timeline are typically struggling pretty hard, oftentimes with fatigue. And so I think that's a justification for me monitoring these patients and helping them cope with their current signs and symptoms. But we really do need to figure out how to make these patients feel better during this time that can last for many years. Oftentimes, patients will ask me, well, okay, I'm on active surveillance. I don't need an indication to treat. How long do I got before I have to start treatment? This study looked at patients who were diagnosed with CLL and looked at how long it took them to require therapy. And they found three factors that delineated when time to first treatment may occur. One factor was unmutated IgHV. Another was absolute lymphocyte count greater than 15,000 at diagnosis, and whether there was palpable lymphadenopathy. And I think what I like most about this score is that two of the three factors can be determined just by having a standard visit with a patient. So patients who had zero factors did not meet their median time to first treatment. And at the last follow-up of 15 years, 80% of patients still did not require therapy. If they had one factor, the median time to first treatment was about 8 to 10 years. And if they had 2 to 3 factors, median time to first treatment was about 2 to 4, 4 to 5 years. And so this kind of helps patients understand how long they might be in this active surveillance phase and gives us justification for how often we need to monitor them. For instance, somebody who has none of these factors, I may not monitor them so often, whereas if someone has all of these factors, I probably would follow them pretty closely. So what do we do while patients are on active surveillance? In addition to recommending all standard of care vaccines and making sure that my patients are getting their standard secondary malignancy workups, such as prostate cancer screening, colonoscopies, breast cancer screening, lung cancer screening for patients who are smokers, there was an interesting study that looked at whether or not vitamin D prolonged time to first treatment in patients in active surveillance. And as you see here, patients who were either on vitamin D or vitamin D analogs had a longer time to first treatment than patients who were not on vitamin D. So I find this very interesting. And given the fact that vitamin D can be acquired relatively cheaply and also has a good side effect profile, I do recommend vitamin D supplementation for all of my patients who are on active surveillance. There was no specific dose mentioned in this article, so typically I recommend 2,000 international units per day for each of my patients. So moving forward, why don't we think about chemoimmunotherapy for patients with CLL anymore? So these two trials, which were published around 5 years ago now, pretty much put the nail in the coffin for chemoimmunotherapy as frontline option for patients with CLL. On the left, we have the EA9161 study that compared ibrutinib plus rituximab to FCR in younger patients and found that the combination of ibrutinib plus rituximab led to a PFS benefit and down the line did lead to an OS benefit compared to FCR. Additionally, we had the A041202 study that compared ibrutinib plus rituximab to bendamustine rituximab for older patients and also saw a PFS benefit for patients who were getting the ibrutinib. Interestingly, rituximab in this study did not add any additional efficacy to the ibrutinib and is the reason why we don't use rituximab as our anti-CD20 partner for patients with CLL. I'll talk a little bit later about obinutuzumab and why obinutuzumab may be the preferred anti-CD20 monoclonal antibody. So now we have these targeted agents. As we talked about before, the main targeted agents that I use are the BTK inhibitors, the covalent BTK inhibitors, acalabrutinib and zanubrutinib, the BCL2 inhibitor venetoclax, and usually I'm partnering that with the anti-CD20 monoclonal antibody obinutuzumab. And I think the reason why these drugs appear to work well either as single agents or in combinations because they have non-overlapping mechanisms of action. Obinutuzumab targets the anti-CD20 on the outside of B cells. The BTK inhibitors target the BTK, which is essential for B cell receptor signaling. And the venetoclax signals the cell to undergo apoptosis through activation on the mitochondria. And so these are the three agents that we're typically using either alone or in combination in various different time-limited or continuous therapies. Let's start off by talking about the long-term results of the covalent BTK inhibitor ibrutinib now that we have them, which is really exciting for my patients, and I know they like to hear. So for the original study, the RESONATE-2 study that randomized ibrutinib to chlorambucil, ibrutinib led to finally a median PFS of around 10 years. And when they looked at overall survival, the median overall survival has still not yet to be achieved, which is really exciting for these patients treated on this original clinical trial. To follow up on this, a recent study looked at patients who were treated on the original ibrutinib clinical trials and matched them to age-matched controls. And what they found was that patients who were eligible for these clinical trials are now living as long as age-matched controls, which is really exciting. So obviously, not all of our patients would be clinical trial candidates for various reasons, but really for these healthy patients who are getting covalent BTK inhibitors, I can reliably tell them that I would expect them to live as long as age-matched controls, which I know that my patients are really excited to hear. So moving on to the second generation BTK inhibitors, this is the ELEVATE-TN study, which studied acalabrutinib regimens versus chlorambucil plus obinutuzumab. The top line is acalabrutinib plus obinutuzumab. The middle line, the purple, is acalabrutinib alone. And the bottom is the chlorambucil plus obinutuzumab. And as you see here, patients treated with acalabrutinib regimens had a significant PFS benefit compared to chemoimmunotherapy. Interestingly here, the addition of the obinutuzumab did lead to a PFS benefit compared to acalabrutinib, and really questions of whether or not we should be using obinutuzumab with acalabrutinib or our covalent BTK inhibitors. In general, I do not do this as I think it adds cost and toxicity, but in somebody who I plan on using a covalent BTK inhibitor in, I might add obinutuzumab on if I need to get their disease controlled really fast. What this slide is trying to emphasize is that patients who are treated with continuous covalent BTK inhibitors who have high-risk disease do just as well as those patients who don't have high-risk disease. So on this top dotted line are patients treated with acalabrutinib obinutuzumab without TP53 aberration, and the bundled 3 lines just below it are patients treated with either acalabrutinib plus obinutuzumab or acalabrutinib alone with TP53 aberrations, showing that patients who have TP53 aberrations don't do any worse than those who don't when treated with continuous BTKIs. And this data is part of the justification on why we tend to favor covalent BTK inhibitors for patients who have high-risk disease. For zanubrutinib, this is the Sequoia study. These patients were randomized to either zanubrutinib or BR, which also showed a PFS benefit as seen here. The patients who had high-risk features such as deletion 17p, TP53 were not included in the main part of the study because at this time we knew that patients who had these high-risk features should not get chemoimmunotherapy. In fact, they enrolled these patients onto a separate arm of the study, so we can't compare how these patients did with chemoimmunotherapy, but what we can say is that the PFS and the OS for patients with TP53 aberrations was quite good here as well, further justifying the use of covalent BTK inhibitors for patients with high-risk features. In terms of time-limited therapy, we still have only venetoclax plus obinutuzumab approved. This might change soon with the recent results of the AMPLIFY study, which I'm about to show you. So this is the CLL-14 study that randomized patients to VO as a time-limited therapy versus chlorambucil plus obinutuzumab, which showed a significant improvement in PFS, and in most recent data published at EHA showed an almost improvement on OS, which was exciting news. This is the Kaplan-Meier curve that we use to say we don't use time-limited therapies for patients with high-risk disease. My opinion on this is that this data is based off of 25 patients. That's why I circled the little 25 on the bottom left. And we shouldn't be making broad decisions on how we treat our patients just on 25 patients. So to go through this data, this top line here are patients treated with venetoclax plus obinutuzumab without TP53 aberrations. The solid blue line are patients with TP53 aberrations, really showing that TP53 is still a prognostic factor for survival when patients are treated with time-limited venetoclax obinutuzumab in the front line, which we didn't see in the ELEVATE-TN study. So this is the justification why I tend to favor continuous BTK inhibitors for patients with high-risk disease, but I don't say that it's something that I do for everybody, meaning that if someone comes in and they want time-limited therapy and they have high-risk disease, we talk about the pros and cons of going on time-limited therapy. And if they still want it, I continue with it. I don't think it's a reason not to give it if a patient really does want it. I mentioned this earlier. This is the results of the Amplify study. So this is hot off the press. This was recently published in the New England Journal of Medicine. The Amplify study compared combination acalabrutinib plus venetoclax or combination acalabrutinib plus venetoclax plus obinutuzumab versus chemoimmunotherapy, showing a PFS benefit here. There also was a improvement in OS for patients treated with acalabrutinib venetoclax without the obinutuzumab. This is partly driven by COVID-19 deaths. I find this data to be quite good and fascinating. And ultimately, when the AV is approved, I likely will be using that as opposed to venetoclax plus obinutuzumab to avoid the infusion reactions and the need for an infusion with the obinutuzumab. But that's a separate talk altogether. Here's the data for pirtobrutinib. Once again, pirtobrutinib is a non-covalent BTK inhibitor. It was specifically designed to overcome resistance to those patients who develop resistance mutations on covalent BTK inhibitors. And here in this data, pirtobrutinib led to a PFS of 23 months for patients who did not receive prior venetoclax and 15.9 months for those who were venetoclax exposed. Mind you, in this data, all patients got covalent BTK inhibitors. So currently, pirtobrutinib is approved for patients who relapsed or have seen prior BTK inhibitor and venetoclax, and I am using it in my clinic. There was another study that was recently presented at ASH that compared pirtobrutinib to investigator's choice that may lead pirtobrutinib to be approved after just one prior line of therapy. So we'll see if that goes through in the next year. This is the data that we have from the Transcend 004 study that led to the approval of CAR T cell therapy, specifically lysocabtagene maraleucel for patients with CLL. Once again, all patients on this study had prior covalent BTK inhibitor. Most had prior venetoclax as well. And this slide is a little confusing, so I'm going to walk you through it. But the top line, the greenish, dark greenish line, those are patients who had a complete response. And the overall survival here for those patients was not reached. The red line is for patients who had a partial response, and the purple line is for patients who were non-responders. That middle line, that blue line, is all patients. And how I like to look at this data is that only, unfortunately, 9 patients out of the 49 had a complete response, and only 12 patients had a partial response. So when we look at this data, there's only a small proportion of patients who found benefit with lysocell therapy. And so it makes me use this drug in a more limited fashion. That being said, when patients have already received a covalent BTK inhibitor and a venetoclax regimen and are on pirtobrutinib, I am thinking about what I should do next for these patients. And if I don't have a trial available, CAR T is certainly an option. Furthermore, there was a recent analysis presented at our last ASH that looked at lysocell plus ibrutinib and found that the overall response rate was practically doubled and the complete response rate was practically doubled compared to this data. So I think that there is room for CAR T for patients with CLL. I would likely pair it and recommend pairing it with a BTK inhibitor if at all possible. But it's really nice to have this now approved for patients who are also double refractory. On that note, that's our update on the treatment of patients with CLL. I hope that you found this presentation beneficial. Thank you for joining us today. Next up is the second video, which will further discuss therapy selection and sequencing in CLL.